reported with enlarged vestibular aqueduct predisposed to hearing loss by perilymphatic fistula formation. Also by endolymphatic hydrox. These are speculations why patient with EVA can be presented with hearing loss. Clinical presentation. Clinical presentation of EVA patient presented to our clinic may present in different forms, either sensorineural hearing loss, either conductive or mixed hearing loss, or vertigo. Sensorineural hearing loss with EVA characteristics, it is predisposed by minor head trauma. Duct, as mentioned, is large. So direct trauma, even if minor head trauma, can cause fluctuation of CSF pressure transmitted to sensory cells. So it is proposed by minor head trauma, barotrauma, prolonged exposure to sun. So we should instruct patients not to expose to one of these. Sensorineural hearing loss may be fluctuating or progressive. But residual hearing, fortunately, allow child to develop spoken language. It is reported that there is no relation between morphology or dimensions of vestibular aqueduct with configuration or degree of hearing loss. Associated inner ear anomaly such as enlarged lateral semicircular canal was also reported. As mentioned, multiple anomalies may coexist with each other. Conductive or mixed hearing loss. It is reported that presence of air-bone gap in cases of EVA. Cause of air-bone gap, two speculations, either third window phenomenon, which appear in this figure. Upper left diagram is normal system. A sound wave enter from external ear to middle ear to cochlea with normal dimension of vestibular aqueduct, narrow, thin, as seen. So it is of high impedance, no pressure fluctuation from CSF transmitted through it. So all sound wave directed to cochlea, vibrating basilar membrane, and process is completed. While in EVA or whatever any other third window phenomenon, for like above dehiscence of semicircular canal or EVA or carotid dehiscence, whatever, sound enter from external ear to middle ear, dispersed. Its energy dispersed into other pathway, not its natural pathway. This is air conduction and this is bone conduction. So conductive element in EVA patient may be third window phenomenon, or it may be hydrox presence cause stiffness of stapes. So no sound wave transmitted from external and middle ear to inner ear, or decreased number of waves transmitted. Conductive hearing loss may occur due to increased endolymphatic pressure, reducing stapes mobility and movement of oval wind. Vertigo. Vertigo in EVA patient characterized by, it is paroxysmal attacks lasting from minutes to hours, occur in childhood or delayed in adulthood. It's mainly presented by hearing loss. Vertigo less than hearing loss presentation. Also triggered by minor head trauma or vigorous physical activity. As mentioned, otoconia is abnormal, is huge giant otoconia. So it predisposes patient to attacks of benign paroxysmal positioning vertigo. Vertigo also may be due to CSF pressure transmission through enlarged aqueduct, damaging hair cell in vestibular system, or abnormal endolymphatic potential, unstable receptor cell membrane, or coexisting lateral semicircular canal anomaly. Also, some patient with EVA reported a vertigo with rapid head turn. Rapid head turn, as mentioned in anatomy, we have utricular tubule and saccular tubule joined together forming endolymphatic duct. Entrance of utricle with an endolymphatic duct forming valve-like action or sphincter. This more protection against the transmission of CSF pressure to our sensory element in cochlea and vestibular system. This valve action isn't present in EVA patient due to widening of system, of widening of his canal. So utricular endolymphatic valve is formed by utricular wall and duct formed after endolymphatic duct enter vestibule and pass through endolymphatic sinus. Here, pressure wave of CSF formed during rapid head rotation travel through EVA and the endolymphatic duct, stimulating the utricle and copula of lateral semicircular canal. Vestibular hypofunction more reported when there is non-specific otological symptom, such as tinnitus or oral fullness. Bilateral EVA causing more vestibular signs and symptoms to be seen. EVA patient may be presented as isolated anomaly or part of syndrome like Pendred syndrome, or coexist with other syndromes like Waardenburg syndrome, gap junction beta 2, cystic hypoplastic cochlea, or incomplete partition type 2. So, coexisting mutation and disorders may occur together, confusing what is the cause of sensory neural hearing loss in this patient. How we diagnose EVA? EVA is diagnosed mainly by CT scan after performing our history, audiogram, tympanogram. Even if tympanogram is present type A with conductive element, so we increase suspicious of EVA. Temporal bone is the key, CT scan is the key to diagnose EVA. Temporal bone is done high resolution CT scan, thin cut. This what appear of our labyrinth in CT scan. Vestibular aqueduct is posteromedial to semicircular canal. I used to search for EVA in this section of axial CT scan in which appear this ring. Ring is formed from vestibule and lateral semicircular canal. Searching for this section, you can see this ring. Behind posteromedial is this dot. This black dot is posterior semicircular canal. The opening against this canal is the vestibular aqueduct. And here we can show shadow of endolymphatic sac. So this section showing us endolymphatic duct. We can compare diameter of this posterior semicircular canal with opening of vestibular aqueduct. When they are nearly equal by our vision, so it is within normal. If there is any difference between both, send for radiologist to read its dimension at points that we said later on. So search in axial CT scan for section with this ring, searching for black dot posteromedially, which is posterior semicircular canal. This is vestibular aqueduct. This coronal CT scan imaging from posterior, A is more posterior, I is more anterior. Vestibular aqueduct can be seen here. It's opening in posterior cranial fossa, more anteriorly vestibular aqueduct, more anterior, till we reach last section. We can see vestibular aqueduct and starting of appearance of vestibule. In this section, vestibular aqueduct not appear. This is vestibule and superior with lateral semicircular canals. Radiological finding in EVA patient. High resolution thin cut CT scan is mandatory in all children with non-syndromic sensory neural hearing loss. EVA diagnostic criteria, we search for 2 points for diagnosis of EVA, operculum and the midpoint. In this section appear, this is operculum, opening of vestibular aqueduct in posterior cranial fossa, and midpoint. We measure both operculum and midpoint and compare it with norms to know if this is enlarged or not. Varieties of vestibular aqueduct. Normal vestibular aqueduct at operculum is less than, operculum here is less than 1.5 millimeter. Midpoint is less than 1 millimeter. This is normal. Enlarged vestibular aqueduct when operculum is more than 2 millimeter and midpoint more than or equal to 1.5 millimeter. This is EVA, according to Madden et al. In between these dimensions, it is borderline EVA. So, any patient with operculum more than 1.5 and midpoint more than 1 millimeter, it is EVA, either borderline or obvious EVA. And this patient is suspicious for hearing loss in future. So it should be kept under follow-up and under observation. Other authors define EVA as when operculum more than or equal to 2 millimeter and or midpoint more than or equal to 1.0 millimeter. Presence of each of them will diagnose EVA. So if operculum within normal range but midpoint is enlarged, it is EVA. Other authors stated that more correct definition of EVA is to measure 2 points. This is coronal CT scan, and this is EVA. They measure vertical and horizontal axis at midpoint. If it is more than 1 millimeter, they diagnose EVA. يبقى vertical and horizontal axis at midpoint between operculum and labyrinth is measured. If it is larger than 1.5 millimeter, it is EVA. This is another radiological classification of vestibular aqueduct varieties according to CT scan. Here, CT scan showing bilateral EVA. As mentioned, we search for this ring, which is vestibule and lateral semicircular canal. This dot is posterior semicircular canal. Compare this diameter with diameter of vestibular aqueduct. Here is enlarged on both sides, bilateral EVA. Another modality to diagnose endolymphatic duct and sac enlargement is MRI. MRI showing soft tissue. So to diagnose enlarged endolymphatic sac and duct, its presence in MRI referring to its enlargement, as normally they are too small to be visible in routine scans, especially sac. Duct may be seen, while sac usually not seen in normal in routine scans. Other investigation should be done in EVA patient is thyroid and renal function. As mentioned, Bendrine is presented in thyroid, inner ear, and kidney. So we search for any mutation in other part of our of patient body. Thyroid and renal function should be done. Genetic screening may be done. How to manage EVA patient? First and most important is to instruct patient not to be exposed to minor head trauma, to strain, to aggressive exercise, weightlifting, anything that increase intracranial pressure, not to harm his sensory cells in labyrinth. If there is any degree of hearing loss, he is hearing aid fitting for hearing aid, a strict follow-up. This patient should be followed up every 3 months at maximum to detect any fluctuation, any progression. If there is fluctuation or sudden sensory neural hearing loss in EVA patient, corticosteroid therapy may be tried. Corticosteroid therapy, prednisolone is taken 1 to 2 milligram per kilo per day, show 85% success rate. What is the role of corticosteroid? As mentioned in physiology, our body compensatory increase sodium channel numbers in labyrinth to cope against the presence of high sodium level of endolymph. Corticosteroid plays the same role, enhance epithelial sodium channel expression and function in non-sensory inner ear tissue, as resonance membrane, semicircular canal duct, whatever in non-sensory tissue. So decreasing extracellular sodium, so decreasing water absorption and against hydrops of membranous labyrinth. Hyperbaric oxygen therapy may be tried when corticosteroids failed to treat sudden hearing loss and showed some success rate in patient. Chemical labyrinthectomy, it is done in intractable vertigo. When vertigo is severe and uncontrolled, chemical labyrinthectomy may be done. Proposed surgical intervention may be, in some cases, endolymphatic sac decompression, shunt procedure. Cochlear implantation, cochlear implant, a patient become candidate with severe progression, hearing loss, which is not corrected by hearing aid and adversely affects school performance, or with more than 3 episodes of significant diminution of hearing within 1 year. CT scans of some children with variable degree of non-syndromic sensory neural hearing loss. This is two CT scans of normal vestibular aqueduct dimension of two children with moderate sensory neural hearing loss. Here we can see operculum less than 1.5 and midpoint less than 1 millimeter. This is CT scan of female child patient aged 7 years old with bilateral sloping sensory neural hearing loss from moderate down to profound. Showing bilateral EVA, we can see dimensions on the left. Both are more than operculum, are more than 1.5 and midpoint more than 1 millimeter. This is signet ring, this is ring appearance, and this is posterior canal. And here, this is posterior canal. This is male child patient aged 10 years old presented with sensory neural hearing loss, but I can't remember its accurate audiogram configuration. We can see that operculum 2, midpoint 1.6, both are more than normal dimensions. Borderline EVA. Here is, this is vestibule and this is canal. This is posterior semicircular canal. We can compare here. Operculum in first two images is within normal. The enlargement is in midpoint. Here, midpoint is within normal, but operculum is enlarged. Take-home message. EVA is the most common inner ear anomaly. A high-resolution CT scan thin cut is mandatory in children with non-syndromic sensory neural hearing loss with measurement of vestibular aqueduct at operculum and midpoint. Vestibular aqueduct dimension not related to degree of hearing loss or configuration. Enlarged vestibular aqueduct reported in sensory neural, more we can see sensory neural, but presence of conductive or mixed not exclude presence of EVA. Thank you.
Thank you so much. It's a very interesting lecture. We have a couple of questions. So are you, do you mind taking 2 questions?
No.
Okay, so if you press on the chat box, you can see the questions with me at the same time. Okay, just a second. Dr. Al-Farhar, can you hear me?
Yes.
I can't open chat.
Perfect. Question?
Thank you. Thank you very much, Dr. Ghada, for the very rich lecture. So my question is about the sound-induced vertigo in cases of enlarged vestibular aqueduct.
Yeah. In third window phenomenon, Tolly phenomena and the Hempert sign is present usually. Tolly phenomena is vertigo induced by sound. The Hempert is induced by pressure changes in external and middle ear. It is present, yes, doctor, of course, in third window phenomenon.
Okay. Thank you.
Thank you, doctor, for your attendance, and thank you for your support.
You did a great job.
Thank you.
We have another question. Let me read it. What is the normal diameter of posterior semicircular canal that you're comparing to?
I don't know accurately in CT scan, but I guess that it is equal to vestibular aqueduct. We can compare it 1.5, but I don't know accurately.
Okay, so the next question is, what is the relation between the size of the VA and the pressure?
Okay, I'd like to get this figure again.
Sure.
This is this figure of third window phenomenon. This is normal vestibular aqueduct and the cochlear aqueduct. Normal duct is long and thin and narrow. This increased impedance of passage of any pressure fluctuation from CSF back to cochlea or semicircular canals or vestibule. Increase the impedance, increase the resistance to transmission of this pressure, protecting our sensory hair cells in this system. enlargement of aqueduct or enlargement of other one of these normal windows in our ear lead to decrease its resistance against passage of pressure or fluctuation in CSF. So fluctuation of pressure in CSF like coughing, sneezing, trauma will transmitted here from this large aqueduct back to cochlea or semicircular canals or vestibule, causing harmful effect on our sensory cells. As the endolymphatic sac is present between dura mater layers, so it is sensitive to any change in pressure in CSF.
Hello, can you?
I hope I answered the question.
Okay. Someone is asking, can you explain VAMP correlation in AVA with conductive hearing loss?
VAMP is one of tests that confirm presence of EVA, as it is VAMP can be detected at lower threshold with larger amplitude.
I think they're asking if you can, what type of VAMP you're doing and how you get the results. That's, I think, I'm not sure if this is what they're asking for.
Actually, in my clinic, there is no VAMP test. I know it's theoretical.
We usually do them with bone conduction. So based on my experience, we do them with bone conduction.
I hope Dr. Fargal answers this. I have no experience, not in my clinic.
Don't worry. I think the last question we're going to take is conductive hearing loss in AVA, the tympanogram be normal?
I'm sorry, sound is interrupted.
Okay, the question is, will the tympanogram be normal in the cases of AVA?
Yeah. We have no pathology in external ear or middle ear. So tympanogram and the pressure change will be transmitted and recorded with compliance, and admittance of tympanic membrane will be recorded within normal. Here we can see, as mentioned, the type A tympanogram, normal tympanogram with presence of conductive element in audiogram, which increase suspicious of enlarged vestibular aqueduct or third window phenomenon.
Okay, thank you so much for your time today, because we're almost done. We're almost done of time. We only have 1 more minute. Do you have anything to say as a closure, Dr. Al-Farhar or Dr. Ghada?
Thank you so much, Laura, for your great efforts in arranging these rich webinars. Thank you, Dr. Fargal, for your invitation and your support. And thank you for participating.
Thank you, everyone. Have a nice day.
Thank you.